Okay, wonderful to see you all today. We're very excited to get started with the Critical Care Medicine Boot Camp. This is a 5-day webinar and seminar covering 5 topics that were most requested from a survey of about 8,000 healthcare workers across the globe. So we're very excited to welcome you. This seminar series aims to strengthen the care of critically ill patients globally. We'll be talking about stroke, traumatic brain injury, diabetic ketoacidosis, sepsis and septic shock, and acute coronary syndrome. This series is made possible through Stanford University, the University of Rwanda, Nairobi University, the Institute for Medical Equity and Global Health, the Critical Care Society of Kenya, and with very special thanks to Stanford's Center for Innovation and Global Health for their seed grant funding. We are also excited to bring together a team from across the globe, including nurses, physicians, emergency medicine doctors, anesthesiologists, surgeons, and critical care specialists. Before we get started, we'd like to set the tone and keep these sessions professional and respectful by going over some etiquette and housekeeping. Respect. Please respond kindly if you disagree with something. Community. We will use the chat and question and answer functions found at the bottom of the screen. Please send your questions and feel free to introduce yourself. Please turn your video on to capture your face or the room if you're with a group. Professional development. To obtain a certificate of attendance, you will need to fill out a short survey at the end of each of these sessions. A link will be provided. Access. This session is being recorded. Your attendance is your consent to be recorded. All presentation slides, webinar recordings, and resources such as guidelines and protocols provided can be found on our online school, the Learning Resource Center. All materials are free and open access. You can either scan this QR code on the screen, use the link, or there's a link found in the chat box. In consideration of our participants for whom English is not a first language, we want to remind you that Zoom has closed captioning available. This feature might make it easier for you to follow along, as the speakers will be using English. Again, for certificates, please note that you will need to fill out the survey at the end of the session. Certificates will be sent to the email address that you provide in the survey. They should arrive by email 7 to 10 days after the webinar. Today, the topic is time-critical management of stroke, and we're pleased to introduce Dr. Maria Marquez, a third-year emergency medicine resident at Stanford University. Maria has a special interest in global health and pediatric emergencies. Dr. Jean-Pierre Rukundo, a senior resident of anesthesiology and critical care at the University of Rwanda, who likes to teach point-of-care ultrasound. Dr. Rebecca Walker is a clinical associate professor of emergency medicine and a global health expert at Stanford University. And I'm Dr. Anna Maria Crawford. I'm also a clinical associate professor of anesthesiology and critical care medicine at Stanford University. With that, I would like to show everyone where you can find the materials for today. This is the Global Learning Resource Center for Perioperative Care, called the LRC. Once you go to the link, you can see the course card for the boot camp here. You have to create an account on the LRC, but it's free. Once you go to the course page, you can see we have the series of 5 webinars listed as modules online. Today is stroke, and you can see that the slides for today's lecture can be found here, as well as a resource library. Once you've signed in and go to the course page for the slides, you can see the slides, stroke slides here. You can advance the slides or go backwards using these arrows at the bottom. Additionally, if you want to download the slides for independent study or to teach others, you can click on this paper clip icon in the upper right-hand corner, and then click on the PowerPoint slide icon here and download the slides. Additionally, you can see on the left, Stroke Library of Resources. Oh, sorry. Apologies, I didn't see that I wasn't sharing that one. Okay, apologies. Okay, you can see the stroke slides are here. If you click on the right upper hand corner, you can see this paperclip icon. You can download the PowerPoint here. Additionally, the Stroke Library of Resources is found in the next module. This library of resources has several bedside job aids, guidelines, algorithms, and protocols. So with that, I'm going to turn it over to Dr. Maria, who will help us, and Dr. Jean-Pierre, who will help us understand time-critical management of stroke.
Hi, good morning, everyone. Thank you for being here. So like Dr. Crawford said, today we're going to be going over kind of a general overview of stroke management. This presentation was prepared by myself and Dr. Jean-Pierre Rocondo.
Sorry, hold on. Need to enable the chat for everyone.
No worries.
Okay, let me screen share the slides. There we go. Okay, now we should be able to chat and see the slides. Can you see the slides now?
I can, yes.
Wonderful. Okay.
All right, can we go ahead and move on to objectives? Awesome. All right, so today for you, we're going to provide you with a definition of stroke, and we're going to help you distinguish between the two different types, which are ischemic and hemorrhagic. We're going to talk about some of the epidemiology of stroke, just prevalence, incidence, and global burden. We're going to teach you about the underlying mechanisms of stroke, especially between the two different types. We're going to talk about key diagnostics and methods that are used to evaluate stroke. We're going to review the current recommended treatment guidelines for both types of strokes, ischemic and hemorrhagic. We're going to review potential complications you may encounter in stroke management and with treatment. And then we're going to outline some preventative measures that can be taken for stroke. And then lastly, we're going to hopefully you'll be able to understand the challenges that can happen with stroke evaluation in different healthcare settings and capacities. This is just a broad overview of our presentation today. Just more broadly, we'll be doing an introduction, we'll do the definition, the epidemiology, we'll talk about types of stroke, then risk factors, as well as the pathophysiology. We'll talk about signs and symptoms, different investigations that can be taken. We'll talk about management, complications, and preventions. And throughout this presentation, we'll also work together through a stroke case while we're going over all of this information.
Thank you, Dr. Maria, for good introduction. We started by definition of stroke. Normally, we talk a stroke when there's the part of brain tissue which is not receiving a blood flow. This can be originated from the vascular origin, when there is this part of brain which is not receiving the blood perfusion, there will be the abrupt onset of neurological deficit. This neurological deficit have to be persistent more than 24 hours. In this condition, you can say there's a stroke. So in telling a stroke, we can classify clinical classification of stroke by three categories. We can say transient ischemic stroke, or progressive stroke, or complete stroke. We say the transient ischemic stroke when those rapid onset of neurological deficit due to poor brain tissue perfusion resolve within 24 hours. In this condition, we say the transient ischemic stroke. Then we say progressive stroke when there is those neurological deficit, which is progressive with time. In that condition, we can say there's the stroke in evolution. But if those focal neurological deficit persist, here we can say there's a complete stroke. Here in this way, we can define as a stroke. The question we can ask ourselves, does a stroke a burden worldwide? Yes, the stroke is a global burden because the stroke, it is a leading cause of disability worldwide. And the stroke is the second leading cause of death. The research done worldwide showed that in 10 years from 1990 up to 2019, showed that there's increasing of the incidence and the prevalence of stroke. The incidence in 10 years showed that there's increase up to 70% of incidence of stroke. About the prevalence, it up to 102. And then about the death from stroke, the people get stroke, 43% death are due to the stroke. So we can ask about the stroke in the lower and the middle income country versus the stroke in high income country. The research showed that the death and the disability from stroke, it is decreasing in a high income country, but increasing in the low and the middle income country. About the death of stroke, 6% of death due to stroke are found in the low and the middle income country. And about the disability, 89% of disability of stroke are found in the low and the middle income country. By here, you can understand how much a stroke is the worldwide burden, and everyone has the right, has the responsibility to fight against a stroke and to be involved in the prevention of a stroke. And we know above 80% of stroke are caused by reversible cause of stroke. It means if everyone has responsibility to be involved in the prevention of stroke, the incidence and the death due to stroke can be reduced. So for making this presentation more practice, let's talk a case. Here we have a patient who has 76-year-old female patient. This patient has medical history, has the hypertension, type 2 diabetic mellitus, and smoking 20-year per year of smoking. And the patient reported to get previous transient ischemic stroke 2 years ago. The patient was on metformin and amlodipine. And then the patient suddenly get only weakness and decided to speak 24 hours prior to arrival to the hospital. And then apart of that onset prior that 24 hours, the patient was healthy, the diabetes was controlled, the hypertension was controlled, and then those onset of those symptoms appear. And then the patient consulted the traditional medicine where it was not help, and those symptoms persist, and then the family decide to bring to the emergency department, to the hospital. So the question is, can we ask ourselves, what is the main diagnosis on this patient by taking this small information? Another point, what are, by this short history, the risk factor which can lead to this appear these symptoms, these diagnosis? What are the risk factor of this patient, which is the make the patient to fall down in this condition? So let's hear from Dr. Maria to keep understanding about the stroke.
I think if I can just make one comment, Jean-Pierre, I think your request to look at the risk factors for this patient for stroke is very good to point out, because I think it's those risk factors which is making the incidence of stroke go up, especially in the low and middle income countries. And just to point out that the mortality rate in resource constrained settings is much, much higher than the mortality rate in the high income or high resource settings.
Great. So I'm going to bring you back to that first definition of stroke, and we're going to expand it further. So stroke is actually categorized into two main types of strokes. We have ischemic and hemorrhagic strokes. We can also talk about hemorrhagic strokes in that they are further subdivided into intracranial hemorrhage, or ICH, and then subarachnoid hemorrhage, or SAH. The incidence of these globally is estimated to be around 85% for ischemic strokes and 15% for hemorrhagic stroke. I do also want to point out that although ischemic strokes are more prevalent, hemorrhagic strokes actually result in more fatalities and what we call loss of disability adjusted life years. So here we have just the visualization of the two different types of strokes. We have ischemic, which, as you can see from this picture, is broadly kind of categorized into blockage of a vessel. And then hemorrhagic stroke, which is broadly defined as like bleeding in the brain. All right, so getting into more specific definitions for these two types of strokes. Ischemic strokes, like I said, are caused by blockage of a vessel in the brain. This is most often an artery, although there are some very rare cases where it can be caused by a blockage in a vein, but we'll focus on the main one, which is the artery. We think about this occurring in kind of three different mechanisms. First one is thrombotic strokes, which are basically a product of atherosclerosis, or disease in the vessel. For thrombotic strokes, we think about the MCA, or the middle cerebral artery, as being the most commonly affected. Next, we also think about embolic strokes, or embolus/blood clot that goes from the heart up into the vessels of the brain and gets lodged. We think about things like atrial fibrillation, in which a clot may form in the heart and then gets thrown up into the arteries of the brain. And then we also think about just blood clots or thrombus or flatty deposits, which we also define as plaque. Basically, what happens is when these arteries experience these thrombotic or embolic occlusions, there's reduced blood flow to a particular region of the brain. And depending on that particular region, it can correlate with specific neurological symptoms or findings.
Maria, thank you for that. And I think it's a really good point that you bring up about the time critical aspect of treating strokes. So why is it critical, if we can think about that?
All right, so keeping time as being a critical factor in mind, I think we have to understand the pathophysiology behind strokes to understand why time is so critical. So this basically all comes down to what you might commonly hear people say is that time is brain. So the brain requires a constant supply of glucose and oxygen, which all come from the blood flow. And the brain maintains its blood flow through something called autoregulation, meaning it's able to kind of change different factors that will affect its blood flow to either receive more or less. We can think about how much glucose and oxygen and energy the brain needs. We can think about the fact that the brain accounts for actually 20% of our total body oxygen consumption. It's a highly aerobic tissue in which oxygen is going to be the limiting factor. It's going to be that main energy source. And so when we have lack of blood flow to the brain, to a particular area, we have death of that brain tissue. And this can occur as fast as within 4 to 10 minutes. So the big kind of driving factor here for ischemic strokes is ischemia, or lack of oxygen. To put it into a perspective, just more quantifying it, it is thought to be that about 16 to 18 milliliters per 100 grams of tissue infarcts within the hour for brain tissue. And then 20 milliliters to 100 grams of tissue to minute ischemia without infarction, unless it's prolonged for several hours or a day. So this is kind of like the residual effects later on. All right, and then thinking about our patient, which Jean-Pierre kind of polled the group, we wanted to think about risk factors for this patient. And so here are all of the risk factors that are generally associated with stroke. We define them into 2 different categories. We have non-modifiable, which essentially are things that we cannot control, things like age or gender, a family history, if you've had a prior history of stroke or TIA, any genetic disorders that may predispose you to stroke, or formation of these like plaque or emboli. And then we think about modifiable risk factors, which are things that we usually can control, things like behaviors and exposures. So things like hypertension, diabetes, smoking, dyslipidemia, or issues with cholesterol, heart disease, obesity, our physical activity, or our diet.
I'm just going to interrupt for just 1 second, Maria. We are super excited to have so many people join us today. We have, just as a reminder, we have the chat box feature. We also have the question and answer feature. So if you want to submit a question, please put it in the Q&A, not the chat box, so that we can answer questions at the end of the session. Thank you.
So thank you, Dr. Maria, for explaining well about the ischemic stroke. Now, as the stroke has the many types of ischemic stroke and the hemorrhagic stroke, now let's talk a bit about the hemorrhagic stroke. So when we say hemorrhagic stroke, we say hemorrhagic stroke when there's a rupture of vessel into the brain. The main form of the hemorrhagic stroke, we have the intracerebral hemorrhage when there is a bleeding into the parenchyma, or subarachnoid hemorrhage when the bleeding into subarachnoid space. So when you say about the hemorrhagic stroke, the main vessel which is ruptured is the middle cerebral artery, And by this breeding, there's the common site of those breeding where we can find the main site of we found the breeding or the hematoma in about the basal ganglia. So we can ask the cause of this hemorrhagic stroke. The main cause of hemorrhagic stroke is the hypertension. Hypertension is among of the cause or risk factor which is caused this hemorrhagic stroke. Another is aneurysm. Another cause of the hemorrhagic stroke is the arteriovenous malformation. Also, the trauma contributed to hemorrhagic stroke. So we can now explain what behind after hemorrhagic stroke, what is the mechanism, what is the pathophysiology behind the hemorrhagic stroke. We can devise the mechanism of hemorrhagic stroke in three main parts. The first one is the breathing. When the rupture is breathing into the brain, there's a collection of the blood or the hematoma into the brain. That is the first one. The second is due to the mass effect. Depending of the expansion of the hematoma, when the hematoma expand, of course, there will be the increase of the intracranial pressure. The pain of the increase of intracranial hematoma, there's the effect related to that intracranial hematoma. Of course, such as there's the impairment of brain tissue perfusion. Another point, there's the herniation, which can aggravate the situation. So apart of the hematoma, there's the blood substances such as the iron or other blood substances which contributed to the neuron damage. Those iron or other substances, they cause the oxidative stress into the brain, and then those oxidative stress contributed to neuronal injury. So apart that, there is also the inflammatory mechanism. Those hematoma into the brain, they trigger the inflammatory markers, the cytokine and other inflammatory markers. And those inflammatory markers, they make the hematoma into the brain. Those hematoma also contribute to ICP. Those all mechanisms make the increase of ICP. Those ICP also contributed to a reduction of other brain tissue perfusion, and also to secondary brain damage. And in that point, the patient can develop a neurological deficit. That is why in a stroke, even ischemic stroke or hemorrhagic stroke, the early diagnosis and the quick management contributed to the good evolution on the outcome of the patient, because when there's a delay, those all mechanisms which contributed to brain tissue inflammation, it will worsen the situation of the patient. That is the summary. How can I explain about the mechanism behind when there is hemorrhagic stroke? So.
Thank you, Jean-Pierre. Those are excellent points. I think that you make in that the management of stroke is time critical, because if you don't manage it well early, then you have a lot of secondary injury. So thank you for pointing that out. I think that's an excellent thing for all of us to take away.
Thank you, Prof, for the good input. So, of course, when you say also the hemorrhagic stroke, we have to understand that there's the difference in the cause or risk factor. In the form of those hemorrhagic stroke, the risk factor, it is the very important, because always when we reduce or we remove the risk factor, or the incidence of developing a stroke, it is decreasing. So as we said in many causes of stroke, we're saying about the hypertension. Hypertension also is still the cause and risk factor of hemorrhagic stroke. Of course, those the aneurysm, patient who has the aneurysm can be the cause or the risk factor. Another point, the patient who gets cigarette smoking, a high risk factor to develop a stroke. Why? because those cigarette, there is the damage of the vessels, the vessels into the blend, and the risk of the rupture of the vessels is increased. And also the people who have heavy alcohol consumption, they have a high risk of developing the stroke, hemorrhagic stroke. Another point is a chronic liver disease. Of course, when you say chronic liver disease, we have to understand the coagulability. The coagulability also, it is another point which can contribute to hemorrhagic stroke. At the point of age, they say male sex cells contribute. Other point is the tumor. Of course, the tumor, there's the risk of the vessels, of rupture of the vessels near vascularizing the tumor or near the tumor can be. Another point is a trauma. Trauma also is another risk factor which contributed to the hemorrhagic stroke. Another point we can't forget, the patient who has the ischemic stroke, who is on treatment, those thrombolytic can complicate to the hemorrhagic stroke.
Thank you. Yeah, those are all very common risk factors. I think we often see trauma, especially with road traffic accidents, that can lead to hemorrhagic brain injuries. What are some of the early signs of stroke?
So, about the clinical presentation of stroke, the patient can differ to other patients because the patient can present to other, with this clinical presentation, another patient can present with the other symptoms. But in general, the patient depend of the origin of the bleeding, or depend of the ruptured vessels. The patient can present the different symptoms depend on the part of the brain which is damaged. But in general, the patient can develop the aphasia, dyslexia, or the vision loss. Patient can develop the motor weakness, like motor power can be decreased, depend of the aggravation of situation, or the sensory can be also attacked with the loss of sensation, or decrease of sensation. And the patient also can develop the attainment of status or confusion of seizures. Those are the symptoms the patient can present. Patient can present 2 or 3 symptoms or many symptoms, depend on the aggravation of situation. But for summarizing the clinical presentation, we can use like a mnemonic where we can use the be fast. Be fast is simple to get it. Everyone can get it as a take-home message after this end of presentation. At least everyone, as Dr. Maria said about the objectives of this presentation, at least everyone at the end of presentation will be able to diagnose the hemorrhage, the stroke. When you say be fast, the first one, B, is the balance. The patient lost the balance and can get the dizziness, or the ear about the vision loss or blind vision. Patient can get the facial weakness, or facial dropping in one side. Or another very sensitive is the hemiparesis, like in upper limb or lower limb. Or also patient can get this difficulty of speaking, speech disability. One of these symptoms, when it appear, you have to get attention. It's the time to call for help, or to consult the emergency, to consult the hospital, to consult a doctor for more investigation and more assessment.
If I can take a minute right now to summarize some of the things that you have said. We have the Be Fast is a good way to remember how to detect a stroke. Sometimes you'll also see fast instead of Be Fast. But stroke detection is really the first step in managing these patients. And from there, we need to figure out their history and risk factors that makes it more or less likely that the patient is having a stroke. But also then we need to determine if the patient is having an ischemic stroke or a hemorrhagic stroke. I want to also just remind the participants that this BFAST algorithm is a good example of the resources that you can use at the bedside or whenever you suspect you need to manage stroke. And it can be found in the resource library that is on the Learning Resource Center or the LRC. And that link should be at the top of the chat box. But thank you. I just did want to make sure that we have a good idea of the flow of the management. So first is detection. So we're starting to get into that now with BFAST.
All right. So in terms of identifying further if this patient is having stroke or not, we need to do a thorough history and physical exam. I just want to point out that kind of some of the key factors or key history elements that we should be gathering are listed here. Obviously, there are many more components to a patient history, but these are things that we're looking for when we are trying to diagnose a stroke. So one of the key things that we want to ask the patient is, when was their last known normal or well? When was the last time anyone saw them at their baseline? And we also want to think about, like was previously mentioned, their past medical history. What risk factors do they have that may contribute to one stroke versus the other? What associated symptoms do they have? This can kind of also help us determine or help us lean more towards if it's hemorrhagic or ischemic. And then one of the kind of classic history components that they teach us is if the patient complains of a sudden, very intense headache, that can usually be more attributed with like sudden onset bleeding, like with a hemorrhagic stroke. With our physical exam, we want to focus on a neurological exam. And while there's, all of the different components that we would actually assess, the motor, the sensory, the coordination, the cranial nerve exam, assessing speech, assessing coordination, balance, and cognitive testing, a special tool that we can use while doing a very quick focused neurological exam is the NIH stroke scale, which is also referred to as an NIHSS. And this can be very helpful in helping us differentiate kind of what the next steps are for this patient as well as management.
Can I ask, why is it so important and why is it in bold on your slide that we know the last known normal or well?
Yeah, so we'll get into this a little bit later and talk about it in more detail. But essentially, the big key thing here is, like we said, time is brain. And so we want to know the last time they were normal or well, because that can help guide what therapeutics we can give this patient and what interventions can be done in order to save the most amount of brain tissue possible.
Thank you, Dr. Marquez. I think one thing that we've talked about different conditions that can mimic a stroke, or at least like some of the symptoms. And we all know that different syndromes or pathology can cause some of these symptoms. I think one of the things that we've talked about, all these risk factors that are going on in some of these patients that are signs that they are at a high risk for a stroke later. So even if you do figure out, maybe the reason for these symptoms are something other than a stroke, then it's, we treat kind of a TIA or a stroke exactly the same in a lot of ways. We start checking cholesterol, we check for high blood pressure, we make sure that we're kind of optimizing these patients to avoid the potential for a stroke downstream. So let's go over some of these conditions that can mimic a stroke. But when the patients are having these symptoms, then we have in the back of our mind, even if they're mimicking a stroke, and they doesn't seem like they had a stroke, how can we prevent a future stroke?
Awesome. So yeah, I think we are getting into kind of the workup of a stroke and really thinking about that diagnosis. But in the back of our minds, it's also very helpful to keep other more temporary conditions that can also have some neurological symptoms or signs on exam that are more easily fixed than a stroke. And so I just want to very quickly mention that things like hypoglycemia, more low blood sugar, changes in the sodium levels or hyper or hyponatremia can mimic some stroke symptoms, uremia, things like a metabolic encephalopathy, hyperthyroidism. There's certain types of migraines that can produce neurological symptoms, seizures. There can also be psychological disorders and things like brain tumors. So all of these can also produce symptoms similar to stroke, but we also want to keep in mind because in order to treat a patient for stroke, we want to be sure that they are actually having one.
This is where we keep in mind that the timing of the onset of the symptoms, and then also a quick history to determine if there's risk factors present. Is that right?
Correct, yes. Or if any of these other things may be going on.
Great.
All right, so we're going to dig a little bit deeper into the neurological exam, and particularly the NIHSS score. So this is a scoring system that was developed by the American Stroke Association under the American Heart Association. And it's a tool that was made for healthcare providers to help them evaluate the severity of stroke and then use that to determine what the appropriate treatment could be for the patient, as well as help predict outcomes for the patient. We have a QR code here on the slide, which you can use to access the NIHSS kind of PDF, which includes both the scoring system and also has further instructions as to how to conduct each portion of the exam and score appropriately. But I just want to give a brief overview and let you know that this is a scoring system that is composed of 11 different items, and you score each ability between 0 to 4. So 0 typically indicates a normal function in the patient in that specific ability, and then a higher score, usually 3 or 4, depending on the category, is indicative of a higher level of impairment within that ability. And so at the end, you take each point from each category and you add it all up. And you can categorize a stroke into minor, moderate to severe, or severe based off the score. So a score of 1 to 4 is usually a minor stroke. 5 to 15 is what we consider moderate. 16 to 20 is a moderate to severe, and then 21 to 42 is a very severe stroke. So if we can think back to our patient in our case that we've been going through, we now do a physical examination of this patient. And the part I'm going to focus on is the neurological exam. So in terms of a quick cranial nerve exam, we notice that she has facial asymmetry with drooping of the right corner of her mouth. She has decreased sensation to the right side of the face. She's going to have decreased strength, 2 out of 5 in the right upper and right lower extremities. So just contraction against gravity. She has normal strength on the left side. She has decreased sensation to light touch and pinprick on the right as well. She's hyperreflexic on the right side and also has a positive Babinski. You notice that her speech is dysarthric and she has word finding difficulty. And then lastly, she's unable to ambulate due to this weakness on the right side of her lower extremities. So for this particular patient, this is what her NIHSS would theoretically look like. So she would score points for facial movements, so complete unilateral palsy of that right side. She would also score 3 points for her motor function of the arm. So she would get 3 points for this. Moving on to motor function of the legs, she would also get 3 points for the right side for no effort against gravity. For limb ataxia, she had it in 2 limbs, her right arm and her right leg, and so that would be 2. Sensory, she has mild sensory loss to the right side, so that's 1 point. Language, she was mildly aphasic, and so we gave her 1 point for that. And then she was also dysarthric, so we gave her another point for this. And then lastly, for 11, she got 0 because she did not have any extension or indentation. And so we would take that and add up all the points from each category, and we would see that this patient actually scores 14, which would indicate that she would be having a moderate stroke. So once we get the initial NIHSS score, we would conduct our usual diagnostics, labs, imaging are usually most important. This is both to rule out any of these stroke mimics, to make sure that the patient is actually having a stroke, and then also will kind of help us, determine next steps in treatment, and also prognosis as well. Particularly, emergent / important diagnostics would be CT scan, would be kind of the most important because it's actually the initial step. According to the most recent American Heart Association and American Stroke Association guidelines for management of stroke, they recommend that all patients suspected of experiencing an acute stroke should undergo emergent brain imaging on their arrival before we initiate any sort of therapy. And so for this, non-contrast CT and MRI are usually considered the most appropriate modalities to assess this. Particularly, we want to exclude intracranial hemorrhage. So in a facility where these imaging modalities may not be available, we should definitely consider transferring the patient if we suspect that they're having an acute stroke.
So I would
Thanks,
say,
Dr. Oh.
no, sorry, Rebecca. I would say that globally, especially in places that don't have high resource or not highly resourced, that MRI is going to be a lot less available, and CT scan can even be quite the challenge. But that is important for us to recognize that if we do have a center where CT is available and there's time and resources to do so, the patient should be transferred to a CT scanner if available. And the first scan you can do is just a non-contrast CT of the head, and that will at least tell us if there's blood or not blood. So that'll help us distinguish between ischemic stroke and hemorrhagic stroke. What were you going to say, Dr. Walker?
Yeah, kind of similarly with CT scan, there was a question in the chat about how do you diagnose ischemic versus hemorrhagic without a CT scan? And unfortunately, we really can't. But there are risk factors that make one of those more likely, for younger age, and also epidemiologically, just in different areas, hemorrhagic stroke might be just as common as ischemic strokes. But given that the treatment or possible treatments for ischemic stroke can be detrimental to someone with a hemorrhagic stroke, we always want to do no harm. So we would not give some treatment for ischemic stroke before having a CT scan. And then, there was a question about how do you tell the difference between a TIA and a stroke if fibrinolytics are to be given. And, we wouldn't give any fibrinolytics to someone whose symptoms have resolved. And that's kind of the part of the definition of a transient ischemic attack, is that it is transient, and for it to be transient, it has to have resolved. So that's kind of what we're trying to figure out with all of this imaging. So if we see a sign on an MRI of ischemia, then we think that that was not actually transient, that it has caused damage. So the tissue damage on the MRI is visible.
Yeah, those are excellent points. Thank you. And I think that Dr. Maria and Dr. Jean-Pierre are going into this in their presentation. But a lot of it is the situation around the patient. If it's a young patient who suffered from a trauma, then it's more likely probably a hemorrhagic event from the trauma itself. And so we certainly would not give them thrombolytics in that situation. If it's an older patient with high blood pressure, diabetes, and likely high cholesterol, with the acute onset of stroke-like symptoms, then it probably is more ischemic, but we still need to make that diagnosis on imaging to ensure that the patient's not at risk of having additional bleeding from our intervention. So we have to be very careful, and probably would not give the thrombolytics unless we made the diagnosis on imaging.
So for our patient, she underwent some of these diagnostics. Luckily, we were at a center that could get a CT head and a CT angiography. Unfortunately for our patient, though, she was found to have a hypodensity in the left middle cerebral artery territory, which was consistent with an acute ischemic stroke. She then on her angiography was noted to have occlusion of the left middle cerebral artery, which we think is what caused this ischemic stroke. And then, with her routine testing with her EKG, she had normal sinus rhythm. So no AFib, right, is something we would think about in terms of risk factors. With her blood tests, kind of the main one I want to point out is a blood glucose, because we can kind of exclude hypoglycemia as well with this. And then with the lipid panel also lets us know about another risk factor, the hyperlipidemia. So she does have a elevated LDL cholesterol. And then we also got a coagulation profile as well, mostly to help us with therapeutics going forward for this patient. All right, so the diagnosis for this patient ended up being an acute ischemic stroke in the left MCA territory. I also just want to point out for this patient that we did not see any bleeding or hemorrhage, which will also kind of help guide our next steps in treatment, which is why that initial imaging was important.
Thank you. Let's talk a bit about management of ischemic stroke. So as Professor Anna said, when a patient comes to the hospital, we can't know directly if patient has ischemic stroke or hemorrhagic stroke. That is why when the patient comes to the hospital on emergency, the first time is depend of the gravity, how patient is sick, how if the aggravation of the disease, how patient present clinical manifestation of the patient. The first time you have to stabilize the patient to make sure that patient is stable, and you can start by ABCD approach, and you have to be that the airway is secured and the patient has the normal partner breathing and the patient has good oxygenation, and the patient at least saturating in the normal condition above 94% on room air, or can give an oxygen supplement to be sure that patient has the good oxygenation. And of course, the patient, you have to be sure that patient to insert the good IV line, and the most time the patient present with hypertension. So, and the patient have to control the glycemia, because the patient can present, you can think that patient has a stroke, but he can present with another disease which not the stroke, and can check the glycemia and to be sure that patient not hypoglycemic. And then after stabilizing the patient and after doing the CT scan with non-contrast is when you can say this patient has ischemic stroke. If it's not ischemic stroke is when you can use the contrast, but you can use the contrast when you are not sure the patient has hemorrhagic or ischemic stroke. And then if you find the patient has the ischemic stroke, as we said in introduction, the time is very important in the management of stroke. That is why when the patient present with the within 4.5 hours from the onset of the symptoms is when the patient can be candidate to get the thrombolysis when like those arteplase can be initiated if patient present within 4.5 hours. In that condition, the patient can get the good improvement if the early diagnosis and the good management is initiated early. Of course, if as we said, the main cause of those ischemic stroke is those middle cerebral artery. With those main artery, those mechanical thrombectomy can be done. And if it is done early, within 24 hours, the patient is when those mechanical thrombectomy can be get the good success. And at that point, they insist on the time, the presenting of patient, the timing. If patient present on the hospital early, the good management initiated and the good outcome will be present. That is why, as we found in epidemiology, where the death and disability from the ischemic stroke in high-income country, where the patient can get the good investigation, I mean CT scan or MRI early and get the initiate the early treatment like those the thrombolysis or mechanical thrombectomy, they have a good outcome. That is why the mortality is decreasing or the disability. And I hope this delay of the initiating the treatment and the difficult the condition, the difficult condition for diagnosis can be the behind of the death and the disability in a low and middle income country. I hope this can be the behind of that poor outcome of the patient who develop a stroke in a low and middle income country. So of course, the patient present early after stabilization, after getting the good diagnosis. These thrombolysis or mechanical thrombectomy, most time if they were conducted in early time, the patient gets the good outcome. And of course, the patient can also get antiplatelet therapy like clopidogrel or junior aspirin. But if patient get the immediate thrombolysis, those clopidogrel can be delayed at least 24 hours. So, but not every patient, there's the barrier or the challenging in the management of stroke because not everyone is not a candidate of fibrinolysis because there's the criteria for being scheduled for that the fibrinolysis. Of course, as I said, first to confirm if patient has ischemic stroke, to be sure that there's no hemorrhagic stroke, confirmed by CT scan or MRI, and that is the first one. The second, if the patient get the recent major surgery, like within 14 days, this fibrinolysis is not is a relative contraindication because the risk of rebleeding in that condition. Or if patient has the recent history of intracranial hemorrhage, in that point, the patient also has the high risk to get the rebleeding again. Or if patient has the risk of having coagulopathy, of course, low platelet, specifically if it's below 100,000 by microliter of platelet of ENR, if it's high, above 1.7, in this condition to use a fibrinolytic, there's a high risk of complication. Or if patient also high severe uncontrolled hypertension, And we've seen that a high peak of hypertension is a high risk of developing the hemorrhagic stroke. And we know among of the complication of this treatment of the ischemic stroke is hemorrhagic stroke. So of course, it's good treatment, but you have to get the precaution to avoid the patient to cause more harm in spite of treating the patient. Or if the patient has recently get the lumbar puncture, of course, within 7 days, there's high risk of developing the hematoma, rebreeding. That is why there's, in spite of the good treatment, if they will get the good diagnosis, early diagnosis, and good and early initiating of treatment, but there's the barrier or challenges. So those challenges, of course, as a clinician, you have to rule out all of those for conducting a good treatment without a complication. That is why always in the management of patient, the history is very important. That is why all features, including the history of intracranial hemorrhage, history of the coagulopathy, history of lumbar puncture, those is the information you can capture within the history on the patient. That is why in the management of patient, it's required to get the good assessment, good history and physical exam, and then those information will guide you in a good treatment without causing harm to the patient.
I think,
So,
thank you, Jean-Pierre. I think for those of us who sometimes struggle with having access to CT scans and things like that, it's that supportive care that you outlined that is the most important thing for us to focus on. Those are the things that we can control, even if we don't have access to MRI or mechanical thrombectomy, or even the fibrinolytic therapy. You know, managing the blood pressure very well, managing the glucose, making sure the patients don't have fever. Those are things that we can do that would improve limit the amount of secondary damage from the ischemia or the hemorrhage. Additionally, you mentioned that we should give oxygen to keep the SpO2 greater than 94. I do want to caution us, because if the patient has a good oxygen saturation, we don't need to give oxygen. In fact, if their SpO2 is 96 or greater, we don't need to start oxygen. Oxygen, although is very good for patients with hypoxemia, actually can have a toxicity effect if given unnecessarily. So we do need to be careful with giving oxygen just to give it. We need to give it for the patients that have a relative hypoxemia.
Thank you, Prof, for good supplement. Of course, for sure, in the management for patient, because of those, of course, many patients they present with the ICP, we have to avoid to secondary brain injury to not cause more harm in the management of patient. Thank you for good supplement. So, of course, our treatment has a complication. As I said, when the patient is treating with the those thrombolytic, like IV RT plus, there's a high risk of intracranial hemorrhage. Like they say, 6% of the patient on treatment of RT plus, they develop the intracranial hemorrhage or systemic hemorrhage, which can be at level 2%, or patient can develop angioedema. So, and also the patient who develops, of course, those ischemic stroke, a patient can develop the seizures. So, and of course, if the patient develop the intracranial hemorrhage, of course, the management is changed.
All right, so for our patient, unfortunately, if we can remember, she presented about 28 hours after her initial symptoms. And so she unfortunately was outside of that 24-hour window for thrombolysis. And so we'll see kind of what happens next with this patient. But I do want to talk about hemorrhagic stroke management now that we've covered ischemic stroke management. And so the mainstay of hemorrhagic stroke management is going to be mostly two things, which is going to be blood pressure management as well. And then reversal of any anticoagulation, because bleeding is the major issue here. We want to control blood pressure. It's a delicate balance between, decreasing the pressure enough that it won't worsen the bleeding, but also not making it too low so that then, the brain becomes ischemic. So it's a delicate balance between lowering the pressure just enough, but not too much, because we do want to maintain perfusion of the brain tissue. So for intracranial hemorrhage, the recommendations are to maintain a blood pressure between 150 and 220 systolics. Oh, I'm sorry. I need to correct myself. Sorry. If the patient presents with a blood pressure between 150 and 220 systolic, the target blood pressure is 140. And we want to ideally maintain it somewhere between 130 and 150 for the systolic blood pressure. For subarachnoid hemorrhage, there's two different recommendations. 160 systolic is the recommendation by the American Heart and Stroke Associations, whereas the European Stroke Organization actually recommends something a little bit higher, around 180 for the systolic blood pressure. The big kind of takeaway point for this is that by controlling the blood pressure initially, and what studies have shown is within 2 hours of the onset of the bleeding, and achieving that target blood pressure within 1 hour has shown to significantly improve outcomes for patients. So once we kind of have our blood pressure managed, we also want to think about reversing any anticoagulation, because the big issue here is bleeding. And if our patients are on a blood thinner, that could potentially make bleeding worse, causing expansion of the bleeding, expansion of the hematoma, and increasing intracranial pressure. And so the reversal of the anticoagulation is going to depend a lot on what medications the patient is on. If they're on warfarin, if they're on a dual oral antiplatelet medication, if they're on aspirin. The more specifics of this will depend on what medication the patient has been on or has been taking, but usually tends to be things like platelet transfusion or vitamin K, or this is tends to be more rare in kind of low resource settings, but they have specific reversal agents for things like factor 10A inhibitors that can also be considered. And then lastly, want to talk about—
If I can interrupt again, sorry, Maria. I just want the audience to know that on the Learning Resource Center within the resource library, we have provided an algorithm that tells you how to reverse each of those types of anticoagulants. So if a patient is on warfarin, or if they're on an anti-10A, we have an algorithm that helps people figure out how to reverse those agents.
Yes,
There were a
thank you,
couple of
Dr.
questions in the chat about the blood pressure, and you do want to drop it, as Dr. Marquez is explaining, but what we normally use in the emergency department is something that can be a little short acting, something like nicardipine or labetalol, where we're able to give a dose and then very closely monitor the patient, because we also don't want to drop their blood pressure so quickly. So we want to kind of slowly drop their blood pressure to a goal. And oftentimes that requires a drip of these continuous infusions. So that's sort of how we monitor that.
Just to add on to that, thank you, Dr. Walker. Just to add on to that, if you have an infusion of an antihypertensive that you can use, that would be ideal. Also, ideally, you would have an arterial line, so you can manage the blood pressure really closely. If you don't have an arterial line, you can use a non-invasive blood pressure cuff, but you probably, and especially in the early stages when you're trying to stabilize the patient, you need to check that blood pressure more frequently. So you may actually have them on blood pressure cycling every 5 minutes, every 10 minutes, something like that. versus checking it every hour or every 30 minutes. So you want to check your blood pressure more frequently until you know that you have good control of that hypertension. And yeah, use the agent available to you that is most titratable would probably be the recommendation there.
Great. Yeah, these are all great inputs. In terms of, so that was about reversing anticoagulation and blood pressure management. The next kind of last piece I'll touch on is surgical management, which is not always necessary, but kind of something that may be necessary down the line. This is mostly something that would require some sort of specialty care, probably by a neurosurgeon, which may not also be available everywhere. But things we also think about are hematoma evacuation, so actually removing the hematoma from the skull. This can be done through things like craniotomy. And because increased intraventricular pressure and intracranial pressure are kind of complications of hemorrhagic strokes, we also think about extraventricular drain placement to help relieve some of that pressure. And then because some hemorrhagic strokes are actually caused by aneurysms that have ruptured, the patient can go things like clipping or coiling of the aneurysm to prevent further bleeding or rebleeding, which is also a risk for these types of strokes. All right, just like with some complications associated with ischemic strokes, there's also some complications associated with treatment and just in general hemorrhagic strokes. We think about secondary brain injury or kind of secondary causes of injury that are due to other effects aside from the actual bleeding itself. But kind of once it bleeds once, these types of things are prone to bleed again. And so we can think about other kinds of hemorrhage, like intraventricular hemorrhages that can occur. Increased intracranial pressure is kind of the big one that we've been mentioning a couple of times here. And then hydrocephalus, as these brain tissues expand and swell, it can cut off some of the ducts for the cerebrospinal fluid, which can cause them to swell and not be able to empty, leading to the hydrocephalus. And then delayed cerebral ischemia, which can occur from like compression of the brain, or if certain areas of the brain that are dependent on watershed or smaller sources of blood flow no longer are getting that. Expansion or bleeding of the hematoma, again, increased intracranial pressure is a big issue here. And so that's why we also want to stop or reverse anticoagulation, because if this bleeding expands or grows, it's going to contribute more to this increased intracranial pressure. And then hyperpyrexia or elevated temperature or fevers are also associated with these type of strokes. And so this is also some of that supportive care that we can provide for the patient just through standard cooling, whether it be with like water circulating surface cooling or the catheter-based cooling devices, such as like the cooling through the like Foley catheter. And then if some places have like the kind of those cooling blankets with the fan, those can also be used, but just standard kind of antipyretics like paracetamol or acetaminophen can be used as well.
Thanks, Dr. Marquez. I was just going to point out, part of the reason of following the patient so closely and following their neurologic exam is to decide when a surgical intervention is indicated for these hemorrhagic stroke patients. And we had a couple of questions in the chat about that, like when do you decide to do surgery? And that's why it's important if there's a center where there is a neurosurgeon on call, then these hemorrhagic stroke patients need to be transferred to those centers where a neurosurgeon can make that decision whether that patient needs surgery. But the decision is really based on how the patient is doing clinically. So if they are becoming comatose or becoming more sedated, kind of following their clinical exam.
So one of the things that we worry about with this increased intracranial pressure or expansion of the hematoma or the hemorrhage is herniation. And this is kind of one of the more deadly complications that can result from hemorrhagic strokes. And one of the things that would, require you to consider surgical intervention. And this is herniation. Basically, there's the brain inside of the skull, which is an enclosed space. And so there's not much room for expansion or things to grow. And so as the pressure in the brain or the skull increases, the brain will try to compensate with certain mechanisms to try and decrease that pressure. But when the pressure exceeds the compensation, parts of the brain will start herniating through specific foramina inside of the skull or through certain holes or spaces in the skull. Most of these are formed by the falx and the tentorium. So they're kind of these dense tissues in the brain in which the brain tissue starts kind of sliding and moving around into spaces where it shouldn't be. So we think about these different types of herniation. We have subfalcine herniation, which depending on what part of the brain is being affected can correspond to their symptoms as well. This is also how you can kind of monitor these types of changes. And so this type of herniation in particular will show things like lower limb weakness because this is the part of the motor cortex of the area with the brain corresponds with that motor homunculus, if you can remember where the different faces and the limbs are on this strip of the brain. We have transalar or transsphenoidal herniation. We have tentorial or uncal herniation, which is one of the more deadly ones. This one tends to show signs of what is called ipsilateral anisocoria. So that's when the pupil on one side is much more dilated than the other and is not reactive. And then that will also kind of follow with opposite-sided motor weakness. So uncal herniation is the most kind of deadly complication of this. It kind of tends to happen very quickly and follows kind of these different stages. So first, the patient may show that pupil asymmetry or that anisocoria I had mentioned earlier. That may quickly be followed by some altered level of consciousness, particularly as the midbrain tends to be compressed. It results in compression of the reticular activating systems, which kind of maintains our kind of basic bodily functions. And so that is also an emergency. And then that will eventually progress to what will look like abnormal posturing of the patient, which I'll show a picture on the next slide, but this results from compression of the diencephalon and further compression of the brainstem. And so this is actually a surgical emergency because if this compression or increased pressure is not relieved and the brain continues to herniate, the patient will actually die from respiratory arrest as the medulla is compressed and the patient no longer will have that respiratory drive. So here's a quick picture demonstrating the different abnormal postures that may see. Usually it's one of two, what we call decorticate or decerebrate, and each one corresponds to what part of the brain is being affected or compressed. And so that decorticate posturing will be with the arms flexed and the legs extended, kind of in a very stiff position. And then decerebrate posturing looks like this, where the arms are extended, but the hands may be turned outwards, and then the legs are also extended in a stiff position that may hard to range or move them. All right, so in general, these are things that we can do to try and help with the herniation. Most of these will actually try to address the increased intracranial pressure in particularly. So if the patient is mechanically ventilated, we can hyperventilate them to help cause vasoconstriction in some of the blood vessels in the brain. We can paralyze the patient, especially if they're mechanically ventilated, to avoid certain straining or agitating movements that may further increase the intracranial pressure. Again, like with the blood pressure, it'll be a delicate balance of restriction for fluids. So you want to restrict fluids enough to help decrease some of that swelling, but you also don't want to dehydrate the patient. You can consider diuretics or hyperosmotic agents like mannitol. Blood pressure control, we talked about that delicate balance between maintaining adequate perfusion, but lowering it enough. In patients, particularly with masses or tumors that may be also having this effect in the brain, steroids can help reduce some of that edema as well. And then hypothermia to slow down the brain metabolism. So if we cool down the brain and it's using up less energy, we might be able to save more of that tissue. And then some guidelines have mentioned actually a pentobarbital coma because it is known to reduce cerebral blood flow, but it should also be used with caution because this could also cause hypotension. But the overall goal that we are aiming to reach with all of this is just to decrease intracranial pressure is the big takeaway from all of these measures. All right, so here is a stroke protocol from the American Heart and Stroke Associations. It basically kind of summarizes most of the steps that we talked about and will kind of guide you through what the next steps are depending on what the patient presentation is. As you can see on the side here, we have the time goals. So these are ideal time goals for each of these interventions because time is brain, and so we want to optimize all of this flow of testing and evaluation and treatment in order to save as much brain tissue as possible. We have a QR code here on the side, which will also take you to the American Heart and American Stroke Association page with this protocol that has further detail, and a protocol like this one can also be found in our Learning Resource Center.
So the patient who developed the stroke, ischemic stroke or hemorrhagic stroke, the most of them develop the neurological deficits requiring the long-term rehabilitation. So of course, this rehabilitation of recovery requiring the family involvement and good education about the progress or evolution of the stroke for getting the family help, because the family help is very important in the patient rehabilitation or on a psychological support. Of course, rehabilitation and recovery, it is very important. So the most of goal of rehabilitation, of course, it is the prevention of the more neurological injury, of course, to prevent the contracture or pressure is a prevention, the bed sores, and of course to prevent the inactivity. So we have to help patient to return in normal activity, but it requires the long time. It requires the support of sometimes the family and also the good the physiotherapist or occupational therapy or speech therapy, because it requiring the long time. So you have to think on it and to do good education of the patient, if the and the family for be ready for long-term rehabilitation, because the rehabilitation, it is very important in the treatment of the patient. So remember on the epidemiology where you say the neurology or in disability, I come back in the low and the middle income country, probably we can treat the patient, but if you don't focus on rehabilitation, of course, the patient will the rest of life, he will be with those disability, which is be the burden the family or can be, it is not good. So it's better to go to good rehabilitation and for good recovery, and wait for be ready for long-term rehabilitation and recovery, because those neurological deficits take time for getting recovery. Treatment were initiated early, and the patient then post treatment in acute phase, and the patient get the good rehabilitation and recovery with the family support and with the good settings where they do the good physical therapy or occupational therapy or speech therapy, the patient can get the recovery. So that is very important in the management of patients. So what about the stroke prevention? As we said, the more of 80% of the cause of the stroke, it is the modifiable cause. It means this the cause, the risk which the society can do on it, or the healthcare provider can help the society to change behavior. So that is why here we have the lifestyle modification. About the diet, everyone can change on diet for preventing the cause of a stroke. Exercise, this is physical exercise. This is the everyone. Even you can start with us here who are participating on this webinar. You can start with change our behavior. See if we do the good physical activity. Of course, about smoking cessation, this is the personal decision. This is the high risk, high impact in the developing the stroke. About the hypertension, diabetic mellitus, hyperlipidemia, does the diabetic mellitus, someone can develop diabetic mellitus, but of course the discipline in the diabetic is very important to consult the medical, the hospital, the physician, and to follow the orders. It is very important. Hypertension, the same, to get the good adherence on medication. There's hyperlipidemia. Many people they have hyperlipidemia without the knowing. That is why the screening is very important to everyone to see about the hyperlipidemia and to take a decision according to the result. That is why it's very important. So let's talk about those congestive heart failure of patient with atrial fibrillation. So this can be probable difficulty management, but also to consult the physician is very important, and to follow the recommendation. This is very important. So in summary about the stroke prevention, let's focus that is 80% can be prevented. So that is why all of us we have to be involved, starting by ourselves. We have to focus on prevention of those strokes.
So we only have 2 minutes left, so I'm going to push us through. What are the interventions in post-stroke management that you can take to help prevent complications and secondary strokes?
Come back to our cases. Our case, the patient received the antiplatelet therapy and received the aspirin 150 milligram daily, and then the patient starting the statin, specifically take atorvastatin 40 milligram daily, and the blood pressure was controlled by IV labetalol in the acute phase, and then the patient continue metformin as the treatment of diabetic mellitus, and then the patient receive physiotherapy, and then the patient advised to reduce or stopping smoking, and then to focus on the dietary modification, and then to follow up for a medical checkup. Sure. So in management of stroke, always there is a challenge in stroke management. Specifically, I can highlight where those settings where the access to acute stroke care, because we know that the time and the good intervention is very important. And also the time is very sensitive to intervention. We said about that many times. And also to access to specialist care team, which is not available everywhere. So this is the main challenge. Also on the patient challenge, the patient also patient can get luckily for rehabilitation can need it but cannot find the rehabilitation, and also patient get the knowledge about how to prevent stroke. So those are some challenge in prevention and management of stroke.
Okay, so just to summarize some of the big takeaway points that we talked about today, we talked about early recognition and rapid response. Time is critical for stroke management because time is brain. So hopefully after this, now you'll know how to recognize the early signs of stroke and kind of what a rapid response time frame should look like. We talked about hemorrhagic strokes and how they are strokes that involve bleeding within the brain and usually require management to control the bleeding and control the intracranial pressure. With ischemic strokes, we talked about how these are different because they're caused by blockages in a blood vessel in the brain. These actually require prompt reperfusion therapy, like thrombolysis or mechanical thrombectomy, to restore blood flow to the part of the brain that is ischemic. We talked about a neurological examination and how imaging can help differentiate between the different stroke types, as well as guide treatment strategies depending on what the stroke looks like. And then the last kind of takeaway from this is that care for stroke patients is a multidisciplinary thing. It involves different teams of specialists, from emergency physicians to neurologists to neurosurgeons to critical care doctors, physical therapy, and people who work in rehabilitation. And so stroke patients benefit the most when all of these teams are working together to help them and improve their outcomes.
Thank you so much. That was an amazing presentation. Thank you so much to Dr. Marquez and Dr. Rukundo and Dr. Walker, and to all of you who participated with us today. We're very grateful to share the learning together. A few reminders: if you can answer the survey or poll that was just launched, and make sure that you put in your email address and how you want your name to appear on the certificate. We should be able to email those out in the next 7 to 10 days. Also, a reminder that these slides and a video recording of this session will be available on the Learning Resource Center. That link should be in the chat, but we can put it in the chat again now for reference. We realized that there were many questions that we were unable to answer through the Q&A and chat. We will try to get to those in a separate document called Frequently Asked Questions that should be posted on the Learning Resource Center probably in the next week as well. So again, I'm going to leave the webinar open so that you have time to answer the survey. But I again want to just thank Dr. Maria Marquez, Dr. Jean-Pierre Rukundo, and Dr. Rebecca Walker. Thank you so much.